Hello, welcome again to another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Cardiology. I'm Seth Bilazarian, here with my associate Dr. Srivastava, to talk about a subject that we have touched on in some previous episodes of this program, and the subject is specifically called hypertrophic cardiomyopathy. We've touched on it in previous episodes in our discussions about evaluation of young people before athletic training and other kinds of topics like that, but we haven't handled it straightforward in a straightforward manner, and Dr. Srivastava has agreed to take it on, so I'll pass it over to you.
Well, thank you very much. So like you said, hypertrophic cardiomyopathy is the topic of discussion, and it's a mouthful, the word, but what it essentially means is the phrase cardiomyopathy is just a fancy word for any condition where the muscle of the heart is weakened or abnormal, and there are lots of different types. The type that we're talking about today, called hypertrophic, is a very specific type that's been well recognized and well explained thoroughly, and its hallmark is a thickening of the heart muscle. That's what hypertrophic means. So the heart muscle thickens in a certain way in a certain spot that can render some significant pathology and problems for patients. So once again, the main feature is excessive thickening of the heart muscle. We typically think of it on one particular wall of the heart. However, there's lots of variation. We're learning a lot more about the genetics of the disease and the heterogeneous nature of the disease and how it's expressed. And so there's a lot of variety, but by and large, the majority takes place in one particular wall. Now, heart muscle may thicken in quote-unquote normal people for a lot of reasons. We can sometimes see a little thickening in athletes, well-conditioned athletes, people who have had long-standing high blood pressure. So there's often a fine line in trying to figure out where somebody lies when you start to pick up thickened heart muscle. But the real hallmark and real difference is that the thickened heart muscle and hypertrophic cardiomyopathy is there independent of any other possible provoker.
So hypertrophic, you said, was thickening. So like if you lift weights, your muscle of your arm will get hypertrophy, it'll get thicker. Mm-hmm. And that's a healthy thing. Mm-hmm. You're saying this is a thickening of the heart that's not healthy.
Correct.
And you also sort of alluded to most of what we talk about as cardiologists on this program and in our daily lives in our profession deals with patients who have diseases often in older age. Is that what we're dealing with here?
This is something, I mean, it can be, but by and large, we think this disease can come on in youth, adolescence, teenage years, 20s, 30s, in young ages. And so it actually is, in fact, the most common cause of sudden death in the young. When you hear about a young person, and often we hear about athletes, but any young person who dies suddenly, to me, when I hear these stories, I immediately think hypertrophic cardiomyopathy had to have been that, because it is by far the most common cause. And the reasons are, we'll get into it certainly, but that thickened heart muscle, and underlying in there is something that we refer to as myocardial disarray. And what that means is the cells and muscle fibers have a usual certain type of architecture that's normal. In this condition, that architecture is thrown off and it's in disarray. And as a result of that, it can be a trigger for certain types of fatal heart rhythm problems. And that's what usually is the cause of the sudden death.
So the heart muscle cells, instead of being nicely lined up, I guess we'd say, they might be sort of lined up in a more bizarre way.
Yep. If you look at biopsies under a microscope, that's exactly, disarray is a perfect word for it, because there's no pattern that you would ordinarily see when you look at heart muscle cells. It's in disarray, and that disarray is, without a doubt, a known provoker of certain fatal heart rhythm problems.
How common is this problem?
So hypertrophic cardiomyopathy is actually not an uncommon heart disease, oddly enough. The most recent population studies suggest that it may affect 1 in 500 people in the general population in the U.S., which is a tremendous amount. So based on that, you could say 600,000 to 700,000 people in the U.S. have hypertrophic cardiomyopathy. That's a lot, I think. It doesn't really have any predilection to one race, sex, anything. It's across all races in these population studies. And I came across a statistic about, just to give it some perspective, looking at another commonly talked about genetic disorder, cystic fibrosis. That has a prevalence of 1 in 300. So this HCM, or hypertrophic cardiomyopathy, is 6 or 7 times more prevalent than cystic fibrosis.
Okay. And based on population of the city we're in, Haverhill, we'd expect there's about 80 people in the city of Haverhill that have this problem. So, so tell us a little bit more. You tell us a little bit about the heart, that there's these muscles, the muscle gets thick, and that the muscles are not lined up when you look under a microscope. What other things can you tell us about the heart?
Yeah, so there's a lot of different things. So let's just talk about the heart muscle itself. And again, the major abnormality in the heart muscle is this abnormal thickening, and it's often asymmetric, where one particular wall is thickened. It's probably beyond the scope of this conversation to really get down to the nitty-gritty of the anatomy. However, this one particular wall, when it's thickened, can do a lot of things. In addition to being a substrate for these bad heart rhythm problems, being a trigger for these bad heart rhythm problems, it can also cause what we call obstruction. So what happens, it gets so thick that when the heart muscle squeezes, it squeezes down, it's trying to eject blood out of the heart to the body for the body's muscles to use. The muscle is so thick that it actually blocks that and inhibits that. And that's a major problem and can lead to a lot of symptoms like chest pain, shortness of breath, passing out, dizziness, exercise intolerance. And sometimes the wall, when it thickens, can alter the architecture of the heart valves. And we can see that on certain tests that we do. And that too can contribute to the obstruction and symptomatology that we just talked about. So that's another important, specifically it's the mitral valve we're talking about, can be really affected by this condition because the cords that hold the mitral valve in place often plug right into the wall where this abnormal architecture is found. So that's something. Now, you can have different spots of this thickening. It's less common. The whole heart can be thickened, and that's much less common, 15–20% of the time. You can have just the apex of the heart, the tip of the heart, be thickened, and that's maybe 5 to 10% of the time. I've seen a few of those in my training, certainly, and much less common and a slightly different symptomatology. So that's essentially what you see with the heart muscle. Now, when you want to talk about function in addition to structure, this thickened heart muscle, when we look at tests, it squeezes down just fine. It's not a problem. It's not a weakened heart muscle in the sense of other cardiomyopathies we've talked about in this show. It squeezes down fine. But this muscle is often very stiff and relaxes poorly. It's a restriction, if you will, and it doesn't relax well. And so when the pump squeezes down, it doesn't relax so well. And as a result, pressure can build up. It can back up into the system, so to speak, and cause what we call congestive heart failure type of symptoms. It's interesting to note, too, in the hearts of folks with this condition that more often than not, the other issues of the heart are usually normal. Usually their arteries are normal, coronary arteries. They usually don't have coronary artery disease. And for the most part, aside from that mitral valve thing we talked about, their valves are usually fine, too.
So you said that the heart gets very thickened, and it actually can get muscle bound, so to speak. I tell patients it's like these weightlifters that lift so much weight that they can't even bend their arm because the muscle is so big that they can't even bend their arm. The muscle actually restricts the movement of the arm. Same idea that the heart is so muscle bound, it actually can't even do its job of pumping blood. So that's I think what you taught us about that, but also that there's this stiffness, so it's hard for blood even to enter the heart because it's so muscle bound. Yep. So that's interesting. But at the end of the day, what are the symptoms of this? What do patients feel?
Yeah. So very up front, many people don't feel anything. They can go for years and years and years. You hear about it all the time, and someone just dies suddenly. It's obviously a tragedy, and we come to find out on autopsy that they had hypertrophic cardiomyopathy. So they may have had no symptoms whatsoever leading up to their initial event of sudden death. That's actually not uncommon. But another thing is that many of the symptoms I'll discuss may be underappreciated by the patient themselves because they have had it for their whole life. They've altered their activity level as a result, so maybe they don't take part in certain types of sports because they've always thought that they're just not athletic or not in good shape, and so they change what they do.
Or they attribute it to aging. I'm getting old.
Yeah.
I'm already 30.
I'm hitting 30. I can't do what I used to do, and now I'm getting tired with the stairs and things like that. And so it can be underappreciated. But the symptoms, we can see symptoms in this that you can see in a lot of conditions. So, for example, you can get shortness of breath for a lot of reasons. One, when you're trying to exert yourself, if you have this outflow tract obstruction from the muscle-bound heart, the muscles and tissues don't get the blood they want, you can get short of breath. You can also develop the shortness of breath because of congestive heart failure that we talked about. The pressures build up And a euphemism people will say is that fluid backs up in the system, and that's one way of saying it. You can get chest pain. That's not uncommon. It's usually brought on by exertion, and it's usually brought on by the outflow tract obstruction, and thus the coronary arteries aren't getting the blood and oxygen that the heart wants, and so you can get angina. Is another way. You get chest pain. You can get palpitations. Now, many of us get palpitations or flutters in our. It's very benign for the most part. It's a benign thing. You have an extra beat here and there. But in folks with hypertrophic cardiomyopathy, they are prone to life-threatening heart rhythm problems, so that a palpitation or a sense that your heart's racing may be a sign of something more severe underlying that. And one of the more severe symptoms is exertional lightheadedness or passing out. Again, all from the same reason, that the blood can't get out, your brain's not getting it, you get lightheaded, dizzy, and you can pass out. Now, you could get lightheaded, dizzy, and pass out because of these heart rhythm problems too, called ventricular tachycardia as well, but certainly outflow tract obstruction can lead to that as well.
Unfortunately, some of the things that you just said are sort of common symptoms that we hear about in a lot of other heart issues, or as you said, and people will get out of shape or older. So how do you figure out if a person has hypertrophic cardiomyopathy?
Sure, it's a great point, because all those symptoms you can see in a lot of things. And so first up, go to see a doctor. Being examined, people often have a certain type of murmur that's characteristic of that outflow tract obstruction, and certain maneuvers that can be done in the office to bring it out even more. But that's not the end-all, be-all. An EKG is also important because they're signs of that hypertrophy, of that muscle thickening that we can see on an EKG. So those are some of the most basic initial upfront evaluation that should be done. Now, if there's a real concern for it, because there's some abnormality seen here, family history, then certainly a visit with a cardiologist is warranted, and there are certain tests that we do that are a mainstay of therapy or evaluation. So obviously a physical examination is first and foremost, and like I said, there is a characteristic murmur that we can hear. There's certain maneuvers that we can do that can bring it out even more so, and so that's one part of it. A thorough family history, of course, looking for people who may have died suddenly or unexpectedly. Electrocardiogram or EKG, which is a test where we put leads on the chest and we get a piece of paper, snapshot, and it's an electrical view of the electrical system of the heart. And if someone does have a muscle-bound heart, you can see that. But one of the mainstays of diagnosis has been echocardiogram. It's an ultrasound test of the heart. And we can very easily detect thickening of the heart muscle. Asymmetric thickening is often what we're looking for in this condition. We can make measurements to check for obstruction. We can measure speed and velocities of blood flow, which can tell us a great deal about whether there's obstruction or not, or how significant it is. We can look at the valves and see if there's valve dysfunction, and look at the architecture of the valve apparatus itself. So echocardiography is a very useful, important test. There are other tests that may not be the first line of testing or therapy, but MRI has come to be a very useful, powerful tool in this. So cardiac MRI specifically, nowadays, we can actually, the heart's a moving object, and so in the past, that wouldn't be great for MRI. There'd be a lot of blurriness and what have you, but we can set it to the heart cycle with an EKG running simultaneously, and so now you can get these beautiful pictures of the heart with MRI, and you can get really a good idea as to the thickness of the heart, where scar might be. You can get a better idea of where the myocardial disarray might be, so it's a very useful tool as well.
So you're saying MRI is probably the best, and echo would be second best if we're really strongly suspicious of this problem, but echo is most times really the simplest and the most common way to make this diagnosis. Is that what I heard you say?
Yes, absolutely.
Okay, great. So what about, you mentioned a couple of things, and I actually started off by saying that this is sometimes someone dies suddenly, wasn't known until an autopsy, and we hate finding out things on autopsy.
Sure.
We'd like to find out things before so we can potentially do something about it. So what about this? There's some controversy about screening. Share us about that
as well. So it's funny we're talking about this today because just this past week, many of the major heart organizations came together and put out a consensus statement with guidelines on how to address folks with hypertrophic cardiomyopathy. And there wasn't anything really brand new or earth-shattering, but it put it all together in one place, one document that was easy to access. And so in that document even they touched on screening, and screening in the general population is not recommended. It's just not it's not gonna catch things properly. So just screening a whole population doesn't make sense. However,
well, you use the number of 1 in 500 to just for our audience. If you screen, that means you'd have to screen 500 people to find one of these. So that's just not practical or
it's not practical and cost However, if there's a family member who's been diagnosed with it, such as somebody who's died suddenly or diagnosis in a different way, and then the recommendation is that all first-order blood relatives should be screened as well. So what does that screening entail? It entails sort of what we just talked about, a visit with a cardiologist, and often, what they recommend is, at this point, often going to centers that really specialize in hypertrophic cardiomyopathy. We're fortunate to have these types of centers in Boston. There's certain ones that specialize in this because they see it all the time. They see all the variations of it, et cetera. However, and so, visiting with the physician, a physical exam, an EKG, and the echocardiogram. That's an important part of it. And now there's a lot of talk about genetic testing as well.
Before you go on, you said something that I want to clarify for us. You said that if there is a history of sudden death and a hypertrophic cardiomyopathy has been diagnosed, did you say it, or did you just say sudden death?
Well, no, I meant to say, and if hypertrophic cardiomyopathy has been
diagnosed. So if someone has known hypertrophic cardiomyopathy and they've had certainly ventricular arrhythmia or sudden death, and fortunately they lived and they were resuscitated or they didn't live, you said first-order relatives. Can you help with that?
So parents, siblings, children.
Okay, so all of those people that are connected to that person who unfortunately died need to be screened?
Yes.
Okay.
So, and it's important for some of these folks to be rescreened later. So, the 8-year-old who gets screened now, things can change. And so they recommend actually every couple of years going through some sort of screening up to a certain point. Okay. Now, there's a lot of talk about genetics. We know a lot about the genetics of hypertrophic cardiomyopathy. As of 2010, over 500 different mutations and 11 different genes had been identified as related to hypertrophic cardiomyopathy. There are 3 genes in particular that really seem to be responsible. And it's not a matter of, it's not a good screening test. The genetic tests aren't sophisticated enough to just do screening. However, it can be useful in prognosis and such. I wouldn't just go around checking these genetic tests on random people. Right. It serves no purpose to do that.
Just to step back though a little bit to help our audience, because I think a lot of people now probably know about what genes are, but we simply think about genes as like the blueprint for how our body is assembled. So as you said earlier, that this heart is not put together properly, so it's logical that the genes, that the blueprint is messed up. So you instead of having a house that has straight walls, you have a blueprint that's got all these funny pictures, and the body just follows that blueprint and makes a disordered heart.
Yeah, absolutely.
So you're saying that if it's suspected and it gets further along, sometimes genetic testing can help identify whether the person has a particular kind of that hypertrophic.
Well, so for example, let's say there's a family member who's diagnosed and they start doing genetic testing, all the other family members. There's an 8-year-old who has some of the genetic abnormalities, but on testing, nothing's manifested itself yet. That's the perfect example of someone who needs to be watched very closely going forward, and that's the potency of the genetic test. And so that's where we're at with the genetic testing. I don't think there's a lot more that it's doing for people right now. It's not a great predictor of outcomes necessarily. There's not one mutation that, oh, you got the bad one, and that. There's not so much of that quite yet. All right. But the hope is someday with all this genetic science that you could someday target therapy at the genes and change the course of diseases, but we're not there yet.
Fix the blueprint.
Yeah. We're not there yet.
All right. So you talked a lot about the diagnosis, the symptoms. You talked about how often this is occurring. Obviously, we all want to know, so what do you, if you are somebody who has this, what kind of treatment options are available? Yeah,
so there are medications that can be given when you start to have symptoms. There's not really much in the way of medications just because you've diagnosed it and there's no symptoms whatsoever. These are all medicines that we've used for other conditions we've talked about here. There's beta blocker medication, so some of the names are metoprolol or atenolol or toprol, carvedilol. Those medications can relieve some of the shortness of breath someone might have or chest discomfort someone might have. Calcium channel blockers is actually the one that's been used even more in more frequency, specifically a drug called verapamil, largely used for the same reasons that the beta blockers are considered being used. Sometimes there's another class of drugs called antiarrhythmic drugs that can be used. We sometimes see patients with hypertrophic cardiomyopathy who also have atrial fibrillation. And when you add the atrial fibrillation on top of the muscle-bound heart, it's not a good combination usually. People can feel poorly. So sometimes antiarrhythmics are used for that. So,
but you went through that pretty quick. I want to make sure that I understand that you said, I think, that the first and almost always recommended drug is the class of drugs called the beta blockers.
Correct.
And those beta blockers, examples are like atenolol, metoprolol, those are thought to be helpful on a couple, both because it makes the heart beat less strongly, because the heart is beating.
Or decreases the work the heart has to do.
Right. And the second thing is it reduces the likelihood, we think, perhaps, of the chance of having one of these irregular heart rhythms.
Yeah, it can help. And there's other treatments that we'll talk about more definitive for those heart rhythms that are a standard of care now too. But
the
yes.
first is the beta blockers, and then you mentioned several others, but those would be sort of second tier, like
Absolutely.
verapamil and other kinds of drugs
Yes,
like
absolutely.
that. Okay.
Yep, absolutely. And people who have congestive heart failure, for example, and prone to fluid retention, diuretics are sometimes used as well. The more definitive therapy is something that we refer to as septal reduction therapy. Now, what that refers to is the wall of the heart that's usually thickened excessively is called the septum. It's the wall that's between the right ventricle and the left ventricle, the two squeezing chambers. And that wall is the one that often grows out of proportion to the other. So we're looking to reduce that septum, and that will then reduce the outflow tract obstruction, which is what's leading to the symptoms. The definitive way to do that that's been done for a long time is something called a surgical myectomy. It's a major open heart surgery. The surgeon goes in and will actually cut away part of that wall to relieve the obstruction. And it's often considered the more definitive therapy of choice for this condition. It's reserved for people who continue to be symptomatic despite the use of medications. So it's not the first thing you do when you're first diagnosed, but if you have symptoms, medicines aren't helping, then that's an option. There's another procedure that is also a septal reduction therapy. That's a catheter-based procedure, so much less invasive, and it's called an alcohol septal ablation. It's performed in a cath lab, not major open heart surgery. It's a procedure where it's accessed from the groin through the artery. The catheters are put up near the heart, and it's very interesting. Essentially what we're doing is injecting alcohol into an artery, which then causes a controlled, purposeful heart attack in that tissue that's that thickened wall muscle, and essentially kills off that wall muscle, and over time it thins out and regresses back as it's killed. And so it's an option as well. I think there's some concern from the different medical societies that procedure has been used a little bit more in frequency than some experts might want it to be, because it's much easier to do, and so it's naturally a draw to patients to try that first before trying a big open heart surgery. There's some complications with that. You can develop issues with heart block where you may require a pacemaker. The scar that you are creating by producing a heart attack can be prone to these ventricular heart rhythm problems as well. It's a tough decision often to make, deciding which therapy to go with.
So once you address those kinds of things, you said earlier that there was some concerns about heart rhythm abnormalities because these muscles are not lined up and the electrical energy doesn't flow through the heart normally. So what's the strategy for those?
Yeah, so defibrillators, so implanted defibrillators, which look like a pacemaker, implanted defibrillators, this is what really has altered the course for these patients going forward. And in fact, it's the only therapy to date that has been proven to prolong life in patients with hypertrophic cardiomyopathy. These other therapies I talked about, these surgeries or catheter-based procedures, relieve symptoms certainly, but they don't prolong life. The defibrillator is the only one that prolongs life. And there are certain criteria that renders one at higher risk to have a bad heart rhythm problem. It's not worth getting into all those different criteria, but there are certain criteria, and so those folks often get a defibrillator implanted prophylactically before anything bad has happened. Certainly somebody who's had a cardiac arrest who's been successfully resuscitated, they're a high-risk individual, they get it implanted in this condition, hypertrophic cardiomyopathy. But again, there's a long list of criteria that people can meet. Certain thickness of the heart muscle, certain other features, and so the defibrillator is a game changer for these folks. The pacemaker, just another device, not with the defibrillator capacity, was used for a long time, still is sometimes too. It was thought that the dual pacing the upper chamber of the heart and the lower of the chamber of the heart could relieve obstruction, and it did to some, and it does to some extent. It can, but the reduction in the obstruction is not thought to be that significant to warrant routinely putting pacemakers in as the therapy for that.
So it sounds like that we've had some pretty good review of a really meaty subject, or a weighty subject, or a thick subject, yeah, I guess, called hypertrophic cardiomyopathy. You've done a great job walking us through the incidence of 1 in 500 to the diagnosis using echocardiography, a suspicion in any family who has had sudden death, and the importance of evaluating families, and then talked a little bit about treatment, with the definitive treatment being surgery, where they actually cut away this thickened heart muscle, but also the use of defibrillators and medicines called beta blockers. So that's been a pretty phenomenal, excellent review of a really great subject that we had never reviewed on this program before. So I thank you for preparing that and bringing it to us. Do you have a final word?
Yeah,
or anything?
I mean, the last thing I want to add, and actually it was really a take-home message from this recent publication that I referred to, with these new consensus guidelines, is that hypertrophic cardiomyopathy used to always carry with it a very negative connotation, a death sentence, if you will, and it really has changed. It is now viewed more as a genetic disorder that can be treated. Can people live productive, normal, long lives? And the advent of the defibrillator has really made that possible. And so it is not a death sentence in any stretch of the imagination. And if it's identified preemptively, people can really do just fine with it. And so it's a big change from just a few years ago even.
Great. Well, thank you again, Dr. Srivastava, for a great review of the topic of hypertrophic cardiomyopathy. And you taught us that it's not common, but it's not uncommon either, and that it's something that we should be prepared to think about, and patients should present to their doctor or cardiologist if there are concerns about this in families. So thank you again. Until next time, I'm Seth Bilazarian from Haverhill Community Television and Pentucket Medical Cardiology. We'll see you at next time. Thanks.